So my topic is to talk on MRI and renovascular hypertension. And my aim is, I have no disclosures, and my aim is to review, is to review one case to show you how we use MRI in renovascular hypertension, discuss and compare some of the differences and advantages or disadvantages of contrast-enhanced and non-contrast MRI angiogram, and look at some new insights in evaluating the kidney in renal artery stenosis, and also suggest that the kidney is not the only thing that one can look at with MRI, and one needs to look at other regions as well. So let's look at renovascular hypertension. We've discussed this in great detail in this session. It's obviously 1 to 5% of all the patients with hypertension will have renovascular hypertension. And our aim, therefore, is to use modalities which can evaluate it. MRI has no radiation, gives you good 3D reconstructions. Non-contrast imaging is an option for those with poor renal function. Disadvantages, of course, is that it takes longer examination. There are certain contraindications and contraindications to MRI as well. It's more expensive and certainly not as portable as ultrasound. Here is a 71-year-old female who came to us with a past medical history of type 2 diabetes, hypertension, hyperlipidemias, congestive failure, had a history of pulmonary embolisms and Eliquis, and was found to have hypertensive emergencies. Very difficult to control hypertension. Her hypertension started in her late 20s, when she was 20 years, in her late 20s in her age. She was already on multiple blockers and multiple treatment of hypertension, and the ED added 2 more antihypertensive medications, as you can see. So she came to us for MR angiogram, and the first thing that you visualize is the fact that the left kidney, which has a very nice appearance to it, compared to the right kidney, which has cystic changes and is clearly also smaller than the left kidney. The MR angiogram is performed in a dynamic manner, and what you're seeing here is the aorta, the renal vein to the left side, and the left renal artery. The left renal artery, as you can see here, has a normal caliber to it. The right renal artery was actually somewhat difficult because it was small to begin with, but you can also see that there is an area of stenosis at its origin, an ostial stenosis. We can then do 3D reconstructions to evaluate, to visualize that area better. And this is the left renal artery showing a very nice normal caliber through its entire course. And you can see the right renal artery has an area of narrowing as compared to the distal right renal artery. This patient then went in for an angiogram where they basically noted that we had some very focal narrowing at the area of stenosis, had a relatively longer segment, which was perhaps 50 to 70%, to the area of significant stenosis was at least 70% plus. Patient then went in for a stenting through that particular region. So the first question that we have that I hope I've shown you is that MR angiogram can evaluate the presence of renal artery stenosis. And as you heard from the previous speaker, Dr. Gambhir, he showed us a very nice flow chart where MR angiography can be utilized. So why not CT angiography in these patients? This is the same patient, the eGFR from 30 to 70, and you can see that there was a varying amount of varying eGFR in this patient, but you can see the dip at the date where the patient got her interventional angiography for catheterization. So this patient had a short episode of acute kidney disease, and this is one of the problems we have with intravenous contrast administration, which is why MR perhaps stands a slightly better role in patients with chronic kidney disease. Can phase contrast be used? We used to use it back in 2006 and 2007 when I was a young imager at that time. Phase contrast MR is very similar to Doppler imaging. So if you just think about Doppler imaging and you can think about the jet phenomenon or the dephasing that one we get on MR in that particular area, you can basically imagine how phase contrast MR can add to the presence of the visualization of stenosis in calling something as significant or not significant. Of late, however, we do not use phase contrast MR angiography. The contrast MR angiography, the ability to give high quality imaging is sufficient for most of us to give an accurate estimation of 50 to 70 or greater than 70%. Usually about 50% and plus is something which we are very confident about reviewing. This is an example of a normal patient with a 3D angiogram. And this is a different patient where you can see the beaded appearance that has already been shown by other speakers. of the left renal artery in a patient who's got fibromuscular dysplasia. So we can evaluate FMD as well. This is the same patient shown with occlusion on the left side, a different patient, sorry, shown with occlusion on the left side, a beaded appearance on the right side. And one can evaluate not only for atherosclerotic proximal disease, but one can also evaluate for other causes such as vasculitis and for FMD. So let us look at the sensitivity and specificity of the imaging modality of MR in the evaluation for atherosclerotic disease and in the evaluation for FMD and vasculitis. So the sensitivity and specificity for atherosclerotic disease has been found to be consistently high. Sensitivity is over 90%, not only for the main, but also for accessory renal arteries. Specificity, when you see an area of stenosis and when you try to discuss it as 50% or more, or even sometimes closer to 70%, is very high. With FMD and vasculitis, there's perhaps a little bit more variation depending on the literature in terms of the sensitivity and specificity. The specificity nevertheless remains very high in FMD. Sensitivity perhaps has taken a little bit of a beating. But on the other hand, complications such as the occlusion on the previous examination or the aneurysms that can be associated is extremely high, and one paper even listed it as 100%. What about the use of non-contrast MRI? This is often an area of interest simply because patients may have low eGFR to begin with. And this is basically a study which looked at 400 renal arteries published recently in November 2020 in abdominal radiology. They used a 3T scanner. They used a the steady state free precession sequence, a 3D sequence, which gives you good temporal and, good spatial resolution. And they looked at stenosis as anything greater than 50% or less than 50%. And what they found was that non-contrast MRA was able to correctly diagnose this in 72 patients. It only underdiagnosed the stenosis in 2 patients who were later diagnosed as having grade 3 stenosis in patients with after contrast enhanced MRA. More importantly, the agreement between non-contrast and contrast MRA was excellent. So one can clearly use non-contrast MRA as a modality to evaluate patients with poor renal disease. What we typically use, and going back to the same patient, I started off by showing here are the non-contrast MRA images. You can see that the left renal artery is excellently visualized, is beautifully visualized. You can see the area of stenosis of the right renal artery at the ostium, and this looks very similar to what I showed earlier in the same patient with the contrast enhanced exam. So we typically do use non-contrast techniques as part of our algorithm, even when we do contrast enhanced MRA. Every once in a while, the patient will move, or we will get not such great quality images with the contrast enhanced MRA, and then we revert back to our non-contrast techniques to be able to visualize the renal artery and give the clinician the appropriate information. What are the advances in renal imaging? This is something of interest because Dr. Manoria, who started off the entire session, gave a wonderful discussion on the importance of looking at the aorta for aortic stiffness, for looking at the heart. And then we had Dr. Sharad Sheth and also Dr. V.T. Shah, who basically discussed the importance of the kidney itself in evaluation of hypertension. This is an interesting article by Abu Mawadad from the Mayo Clinic, who discussed hypoxia in the presence of renal vascular disease. And what these basically show is G1, G2, and G3 are different levels of end-stage renal, of lower eGFR and end-stage renal disease. And this is the corresponding regions of severe stenosis that one can see in all these patients. And what they basically showed is that the BOLD, which stands for blood oxygen level dependent MRI, basically shows you the evidence of hypoperfusion, and hypoperfusion is defined as decreased oxygenation on the BOLD imaging. The higher the value that you're seeing, the brighter the color, the higher the R2 star map, and this is an example of a map which basically shows you progression. One can then include this perhaps in the discussion about revascularization in these patients. And the suggestion here is that based upon the differences and the phenotypes that you can see on BOLD imaging, one can then decide which is the optimal time to go in for an iatrogenic an interventional procedure for revascularization, or which is the optimal cases that one can use medical therapy. This is an example also from Mayo Clinic, where they looked at autosomal mesenchymal stem cells, which increased perfusion, and this was the baseline. Remember thank you. Remember the poorer colors, the brighter the color, the poorer it is. And you can see that after 3 months, this kidney actually increased its function based on the presence of R2 star maps that one could see. So this is perhaps something that one can use to further evaluate patients who are on the cusp of end-stage renal disease. Dr. Manoria discussed about cardiac imaging. And this is just an example of a patient who clearly has hypertrophy of the myocardium, and Dr. Elizabeth Joseph from below was kind enough to give me the T1 maps and the delayed enhancement images. One can see the increased signal intensity, which represents an area of fibrosis. And one can also see the same changes on the ECV maps, which basically are able to categorize these patients as to whether they are true HOCM patients or hypertensive-related cardiomyopathy. And this was an example of HOCM, which basically had hypertrophy of the cardiac wall. Similarly, this is something which is an observational study that I've shared with you, which is in progress. It's a clinical investigation, and one can also look for aortic stiffness on CMR4D flow studies, and may be of some interest to some of you in evaluating end-stage renal disease. This was a study which we presented in Los Angeles. We were looking at cognitive patients in the Tata MRI study, and what was interesting for us is that patients who had hypertension actually did poorer in cognition than patients who did not in the cognitively impaired exam, in the impaired patients. And this is just an example of how MRI looks at the presence of white matter changes. So yes, even in the brain, one can basically utilize this imaging. And this is just another example of two studies which have shown that adequate evaluation of hypertension can perhaps even reverse this cognitive changes. So in summary, I would like to end by saying that MRA has a high sensitivity and specificity in the diagnosis. MRA has a high sensitivity in FMD and vasculitis. Non-contrast MRI angiography appears to be equally good, though we always use it as an adjunct and we include contrast enhanced MRI imaging. Bold imaging appears to be something which is of great interest for people to look for the progression of renal disease. And I would also urge all of us to look away from the kidney to look for other changes which can also be equally evaluated in MRI. Thank you again for your attention.